I'm very happy to note that the chairpersons are a person who started this journey, Dr. Shehnaz, and the person who will carry this journey, Anil.
Thank you for saying that.
Yeah. So morphology has been my weakness. So I have been trying to see whatever I have been taught by my teachers, how much the cell counter can match to it. Because my morphology journey has been immense, intense. I just want to see whether cell counters can match to it. So that's what I'm trying to show to you. Okay, I don't know how. Yeah, I have to do this because I can see on next slide. I can see Anil here. Yes, he's the future. So this is a very common scenario that happens in my hospital. The surgical ICU consultant calls me and says that I have got a patient who is very sick. This is a patient who actually had sepsis, was on probably teicoplanin, meropenem, cisplatin, whatever is possible. He was on all possible drugs. He recovered and he is stable and he is going to get discharged from the ICU. But during the morning rounds, the surgical ICU consultant feels that this guy is looking sick. Should we shift him to the ward or not? So he had set the counts as usual and the procalcitonin. Procalcitonin comes as normal. So he calls me and says that, Sukesh, I think this person looks a little sick. Procal has come as normal, he's afebrile. Can you look at the peripheral smear and say whether this guy's got toxic granules? You know, our guys have got so much confidence in the morphology of toxic granules. Can you look at toxic granules and tell me whether it's toxic granules? You know, by the time we have shifted from Leishman to May-Gromwald to right stain to right Jimson, you can imagine how each stain can reflect toxic granules. Some stains will not reflect toxic granules at all. Okay. So I said, let me, okay, I have to use this, sorry. Because next slide I see Dr. Shehnaz and she's not toxic granule. So when you have acute bacterial infection, we know that hematology helps because we know that there is increased white cell count, there can be low neutrophilia, there can be neutropenia also. There's a left shift, there's immature granulocytes, but there's also toxic changes, there is also Dolly bodies. Some stains like Leishman stain will not show you Dolly bodies, but other stains will show you Dolly bodies. Cell counter will reflect all the top four. White cell count, neutrophilia, left shift, and most of the cell counters now actually give you immature granulocyte percentage also. But they will not be able to give you toxic granule or Dolly bodies. But you know, neutrophilia, all the other findings can still happen in other conditions. So let's look at the 5 major platforms that exist in the world. You know, I actually gave this talk 2 days back to Abbott, L&T. So I said, okay, maybe you may not consider all 5 platforms as competitors, but for me, all 5 major platforms are equally good. Now, you must realize when they do a differential count, the entire differential count is based on 2 important parameters. One is the way it lyses the red cells, and in the process how the white cells also get lysed, and also the way the light detection after the processing happens is collected. So for example, some cell counters will lyse the red cells, will keep the white cells intact, but some lice will lyse the red cells. Along with that, the white cells will also start shrinking. Then at the same time, they may have PMTs at various angles where it may not pick up what is necessary and what they want is necessary. At the end of these 2 processes, they collect the signals and they output the signals in such a way where you can depend on size, because size can be real size. Now the real size can only be reflected by certain cell counters, DXH, LNT, Umicin, and indirectly ADVIA. Fluorescence can only be reflected by XN, Beckman, not Beckman, the mind ray and LNT. Staining and light loss can only be reflected by ADVIA and Umicin. In fact, ADVIA realized that actually their y-axis is actually light loss. Nucleocytoplasmic content is only reflected by DXH, but all the cell counters will reflect granularity. That is light scatter. Because if you reflect, if any cell population that is reflected by any cell counter, reliably is always the eosinophils, because eosinophil scatter is higher than any other cell. So scatter is one thing that is reliable for any cell counter, and therefore, and then some cell counters also give you cell population data. That is, you can look at some scatter plot. Okay, वो थोड़ा ऊपर है, थोड़ा नीचे है, but some of them give you data telling that neutrophil average size is this much, lymphocyte average size is this much, monocyte average is this much, scatter of neutrophil this much. You can even have a reference population. There was a reference population that was created in for neutrophils, monocytes and lymphocytes, not only in India, in Switzerland, and in US, and also in India. There are other places like Hinduja in Dr. Shenas's lab, in Dr. Gangaram lab. Anil was involved in that. There was not much of a difference. So that means an average size of a neutrophil is very common among most of the Homo sapiens. So there was a study that was carried out by Fernando Chavez, thinking that if toxic neutrophils have got increased granules, you will have increased granularity. And what is the result of the study? He only found that the neutrophil granularity or scatter was actually decreased. He thought that increased granularity will have more scatter, but he found that it was having low scatter. But one thing he found out was that the size of the neutrophil was always higher. So neutrophil macrocytosis was a good indicator of acute bacterial infection. But he could not explain why there was a... So his conclusion of the study was that increased neutrophil volume was a good indicator of sepsis, but low scatter was also a good indicator of sepsis. How can you have low scatter when you have toxic granulation? When you look at the peripheral smear, neutrophils have got a lot of granules. How come this neutrophil has got low scatter? You have to understand normal physiology. This is something Indian hematology contributed to Beckman Coulter. Simple understanding of basics. That's the importance of Indian hematology, basics. So we told them that when a myeloblast becomes a neutrophil, it takes 7 days. 4 changes happen. The nucleus becomes smaller, flatter, and then segmented so that the cytoplasm can have enough place to kill the bacteria. The granules that you see will start appearing in promyelocyte, in myelocyte, but by the time it becomes to metamyelocyte, you hardly see the granules. That's because as the granules mature, they lose the siloglycoprotein on the surface. And if they lose sialic acid, they will not attract the eosinophilic dye. Only thing is, the granules are there. Only thing is, they do not get stained because there is no sialic acid on the surface. So gone. The granules are there, but they don't get stained. So it's purely a staining mechanism. And then the fourth mechanism is that the size of the myeloblast becomes half. So 4 mechanisms happen during the time the myeloblast becomes a neutrophil. But when there's an infection, this mechanism which happens over 7 days can happen less than 1 day. The only thing that changes over 1 day is the nucleus. It becomes small, flatter and segmented. The blue color does not disappear. It remains as RNA in the neutrophil as Dolly bodies. That's what you see as bluish granules. The granules do not lose their staining property. They appear granular. That's why you call them toxic granules. and the size of the neutrophil doesn't become half. Neutrophil remains large. So, toxic granules, Dolly bodies, large neutrophils indicates neutrophils which have been matured in less than 1 day. So when we did a study, we found that yes, large volumes of neutrophil indicate sepsis. But we also found out that monocytes also can contribute to the diagnosis of sepsis if they are large. So when we came out with the study, we realized that there were only 3 more studies before that which said that large monocytes can indicate sepsis. But they thought that monocytes were actually reactive. But we only said their increased volume of monocytes. So this is a patient with sepsis who's got large neutrophils, they've got more immature granulocytes. But look at the granularity of the neutrophils. They are almost hugging the monocytes. Now you want to say whether monocytes are going to the neutrophils or neutrophils are coming to monocyte. If you look at the lymphocyte population, you know that monocytes are there where they are. They are not going to neutrophil. Neutrophils have come out closer to monocyte. Very simple. In sepsis, we have found out neutrophils are large. They have got the same number of granules like they had before. Larger neutrophils, same number of granules, scatter will come down. So when you have large neutrophils with low scatter, they will start hugging the monocytes. So you must realize one thing. What is being counted as monocyte by the cell counter is not monocyte. They are neutrophils which are large and hypogranular. They are neutrophils which have been produced in less than 1 day. They are neutrophils which happen only during sepsis. That means pseudomonocytosis is a very important sign of sepsis. Swati, one more pseudo for you.
You already published this answer, so this is not now.
So if you have true monocytosis, you can see that you can see a peak here. That's true monocytosis. When you have sepsis, there is no monocytosis. There is no peak here. So sepsis is a good, pseudomonocytosis is a very good indicator of sepsis. Please do not allow a cell counter which will not allow you to identify pseudomonocytosis. Everybody blames monocytes. Every cell counter overestimates monocytes. I'll tell you one thing. Yes, monocytes upper range is 10%. Not 7%, it's 10%. But please do not underestimate a cell counter which shows you that this sample has got more monocytes, because pseudomonocytosis can be a first indicator of sepsis. So please do not underestimate it. So of course, there are other signs of sepsis. Eosinopenia. We talk about, when you apply NABL, you say reference range for monocytosis from DAISY. What do you call? 0.44 to 440, which is 0.4 to 0.44. That is international reference range. You have to use your own reference range, because eosinopenia can be an early marker of sepsis. Look at this. When we use eosinopenia, the area under the curve for eosinopenia of 0.2 to 0.6, that's our reference range, not 0.04 to 0.44, was a phenomenal marker of sepsis. Simple. Eosinopenia was a good mark of sepsis. And at the same time, we realized that cell counters which use fluorescence, like Sysmex, you can see that this patient has got left immature granulocyte, but this patient has got hardly any eosinophils, but the neutrophil fluorescence is high. You can see that higher fluorescence of neutrophils is a very high indicator of sepsis. So when you talk about sepsis, and we are talking about cases where procalcitonin and CRP is normal, only the cell counter data is dependent on. Neutrophilia, neutropenia can be indicator of sepsis. Immature granulocyte can be indicator of sepsis. Neutrophil macrocytosis, which we saw, can be indicator of sepsis. Lower neutrophil scatter can be indicator of sepsis. Changes in neutrophil fluorescence can be indicator of sepsis. Changes in neutrophil monocyte size and distribution can be, or pseudomonocytosis can be indicator of sepsis. And eosinopenia can be indicator of sepsis. Let us see how cell counters handle it. So we saw Beckman-Coulter, we saw Sysmex. Now we have got our own HORIBA. There is no fluorescence in HORIBA other than reticulocyte count. So this is a case here. I can show you. Look at, obviously there's some immature granulocyte. You can see there's a left shift. There's no monocytosis, but you can see that, it's got almost 8% monocytes. You look at the neutrophil volume, it's 190, which is very high. Monocyte volume, which is very high. Let's look at the, we are talking about the same patient, almost 4,000 counts. This is the distribution. If you look at the neutrophil fluorescence, quite high. This is a normal volume of neutrophil fluorescence, up to 50.6. It's 60.3. High neutrophil fluorescence. Like it's same patient, 4.73 count. That's a monocyte is 13%. Look at this. To understand this, let's look at normal. This is the morphology of the patient. So in the normal neutrophil parameter, you can see that this is lymphocyte, this is basically monocyte. Along the x-axis, you got size, along the y-axis, you got light loss. This is neutrophil, and that is more of scatter, and then eosinophils. Now compare this fellow with this fellow. Look at the size of the neutrophil, they have increased along the x-axis. The light loss had decreased along the y-axis. Same thing. Large neutrophils decrease scatter. Large neutrophils decrease scatter. And look at where the monocytes are. The monocytes are merging with the neutrophils. So this cell counter can pick up large neutrophils, can pick up neutrophils which have got low scatter, and will pick up neutrophils which have got merger with the monocyte, which will cause pseudomonocytosis. Yes, this cell counter can also pick up sepsis. Some more cases. This is another case. You see the monocytes and neutrophils hugging each other, pseudomonocytosis. So I've got a 4-year-old male who has got fever, come with low platelet counts. Look at the platelet count, 36,000. Look at the scatter plot. So this is something that Tina is going to talk about tomorrow. I don't want to break the suspense. But we find that this particular pattern will show what is known as high fluorescent lymphocyte count. And we got a publication recently with Anand Vikas from, now he was my student at that time when he started studying. He's now with Newberg in 2021, which showed that this particular pattern and this particular percentage of high fluorescent lymphocyte count is diagnostic of dengue infection. So can only XN pick up dengue? And fortunately I had Anil coming to my lab. He said that when you have the lymphocyte monocyte merger, this is the same patient, same patient. Lymphocyte monocyte merger with almost a teardrop appearance. This teardrop appearance usually is the same as what we see in dengue in Excel. But the neutrophil population looks normal. Okay, let's look at the fact that neutrophil population looks normal. It's less than 150. Let's look at HORIBA. Neutrophil looks normal, but the lymphocyte monocyte merger is possible. Lymphocyte monocyte merger is possible. So, HFLC is not unique to fluorescence lymphocyte, Mindray or to XN. It can be possible with. So, this is a 6-year-old girl from Chittoor. Chittoor is very famous for scrub typhus, ricket cell infection. So, here you can see that there are lymphocytes which are reactive. Is it only lymphocyte that are reactive? So, when we look at the WBC data, we can see that HFLC is 3.4, but the neutrophil fluorescence is high, but the forward scatter somehow looks low. And this 3 of them, when they happen, we can easily diagnose ricket cell infection, scrub typhus. This is our next, I hope Anand Vikas works on the next publication. Same here, you have the same teardrop appearance, but the neutrophils appears large. And if you look at the neutrophil data, it will see that their neutrophils are reacted. Same. Lymphocyte monocyte merger and the neutrophil appearing larger because they have increased in size and they have got decrease in light loss, decreased scatter. This is another case where you got lymphocyte monocyte merger, neutrophils which have become large and they have become low in scatter. So, when you have acute febrile illness, whether it's sepsis, dengue, whether it is ricket cell infection, and I don't have to go about malaria because Dr. Dharap has already mentioned about malaria. And you must also realize that when you start the patient, if suppose you tell the patient, the doctor that the patient has likely to have scrub typhus, they'll start doxycycline, simple doxycycline. And you can see that moment they start doxycycline, all these parameters that you have described which has gone up or changed, they'll all start decreasing. So you can tell the clinician, yes, maybe the serology is negative, but your treatment is effective. So therefore, cell counters can be not only diagnostic, but also telling the patient or the clinician that you are on the right track. Thank you very much. They have got decrease in light loss, decreased scatter. This is another case where you got lymphocyte monocyte merger, neutrophils which have become large and they have become low in scatter. So, when you have acute febrile illness, whether it's sepsis, dengue, whether it is ricket cell infection, and I don't have to go about malaria because Dr. Dharap has already mentioned about malaria. And you must also realize that when you start the patient, if suppose you tell the patient, the doctor that the patient has likely to have scrub typhus, they'll start doxycycline, simple doxycycline. And you can see that moment they start doxycycline, all these parameters that you have described which has gone up or changed, they'll all start decreasing. So you can tell the clinician, yes, maybe the serology is negative, but your treatment is effective. So therefore, cell counters can be not only diagnostic, but also telling the patient or the clinician that you are on the right track. Thank you very much.
in polymorphs and monocytes in sepsis?
So, ma'am, very important question
Yeah.
because
Thank you.
it's got very high significance.
Very, yeah.
But it entirely depends on when you collect the sample and when you process the sample. If you process sample within 4 hours, it will cause hypergranularity of the neutrophils, cause pseudo-eosinophilia, which can predict mortality of the patient within 48 hours of the detection. 48 hours of detection. You know, we say that blue-green inclusions in neutrophils can predict death, but vacculation in neutrophils within 4 hours of sample collection can also be quite detrimental, especially in sepsis.
So we get often neonatal samples, and in that we get 10 to 15% neutrophil having vacculation, large in size. Morphology is totally distorted.
So as long as you're looking at this morphology within 4 hours of sample collection, they have a lot of significance.
How we interpret in our histogram? Any experience?
Because pseudo-eosinophilia.
Pseudo-eosinophilia. I'll check. I have not correlated with this pattern.
Because pseudo-eosinophilia.
Thank you. Thank you so much.
Any other questions?
Yeah.
So we were talking about pseudomonocytosis and sepsis. For oncology centers where we have the BMT and the chemotherapy happening, would it be a similar picture in those cases also?
So it depends on which cell counter you use. So pseudomonocytosis is good for, pseudomonas can only be picked up on cell counters like which has got white cell histogram. Now, if you have monocytosis can be reaction to malignancy. It can be reaction to chemo also.
The BMTs.
Yeah. So thing is in recovery. So BMT recoveries, the most monocytosis is not as important as neutrophils. So don't even bother about monocytes. Don't even bother about monocytes because lifesaver is neutrophils. Don't worry about monocytes.
So we are there at a tertiary care center where patients of sepsis often reach after having taken a dose of antibiotic or so.
Yes.
So how does that would affect our parameters on the?
So if you have a patient who comes in with sepsis who may have had a dose of antibiotic, there are two options. One is whether the antibiotics work or not work, or you may have to escalate the antibiotic. So you must realize one thing, that I am one of the ardent workers on antimicrobial resistant army force. So I am one of the ardent workers of that. So if you feel that the patient is still having toxic neutrophils, it means that the bacteria is not suppressed enough, because the first response to any bacterial infection is the marrow. First response to any particular action is the neutrophil. Neutrophil is the first one. Even if you give antibiotics, it's finally the neutrophils which is going to finish the bacteria. See, like for example, if you look at the neutrophil, they've got multiple things inside that. They've got bacterial nutrifying factor, they've got lactoferrin, they've got the everything, everything they've, finally, it's the neutrophil which is going to remove the bacteria. So if there is a demand for the marrow for the neutrophils, that means the bacteria is still there. So please look at these parameters. They're very important, because that's a very important information for your intensivist or your surgeons or whatever it is, to say that battle is not over. Please continue the battle.
Dr. Arpita?
Sir, pseudomonocytosis, like just to continue on that topic, in some labs it really leads to high smear evaluation rates. So what is your experience around that?
I would request most of the labs to keep the higher percentage of monocytes at 10%.
Yeah, even if it is 10%, in these BMT and sepsis kind of cases, we do have around 25, 35 monocytes coming in, and possibly this is because of that, it turns out to be a little more increase in the smear evaluations.
Yeah, so obviously, when you talk about samples which are beyond 4 hours, I am talking about samples within 4 hours. We are talking about samples beyond 4 hours. you have to set up your own review criteria based on that. See, we set up review criteria based on what we get. So if you're getting criteria which are not usual, you have to set up your own criteria. But please set up your criteria based on not what the cell counter gives, what you see on the cell counters. That is histograms and on the scatter plot.
Any other questions, anyone? So thank you very much for your
Just-
presentation.
Just one more question. Shall I ask?
Yes, please go ahead.
It's slightly deviating from this topic, but have you had any experience regarding presence of appearance of NRBCs just before an increased mortality of the patient?
Oh, yes.
Of course.
It is very, very significant. A very important question. In fact, there is a publication which has said that in patients who are in intensive care, appearance of NRBCs can indicate mortality. But please remember, these are all done on samples which are within 4 hours of sample collection. So if you are working, and there's a study that is already done in CMC, most of the study in CMC is done 10 years back. Data is available, but we probably sit on the data 5 years later, and then we finally write up the data, and when we send the data, they said, oh, this looks like physics data. This looks like geometric data. So please send it to a physics journal. With a lot of difficulty, we published the journal on dengue. We are struggling with the scrub typhus data.
Actually, we had searched for it, but we didn't find much
Oh
data.
my God,
actually.
madam! I'll tell you one thing. NRBC.
There's enough
if you are
literature.
able to identify, NRBCs on the peripheral smear in a patient ICU, you are predicting death.
Thank you.
You are predicting death. But please don't tell them. I did that. When I found blue-green inclusion on a patient, and we found that there was a increase in eosinophils, and Tulsi brought the slide to me, and all my lab technicians came around me, and I showed them this, and in front of them I called the clinician. I said, "What is this patient?" So he described the patient. I said, so why? He said, why did you call? I said that I'm seeing this blue-green inclusion. What does that mean? I said, this patient is not going to live beyond 48 hours. All my lab technicians were checking this patient's life every hour. And he died 24 hours later. And when he died, all of them came and told me, don't do this again. So after that, when I see this, I called the clinicians. I said that whatever you're doing, you're not doing enough. So you can't play God. Never play God.
Thank you. Thank you very much, sir.